Welcome and Nyajong to NPR News in Focus conversation on disparities in distrust and BIPOC healthcare, hosted by Angela Davis. Gulumbeya Gaba. My name is Gaba, and I'm the Director of Community Engagement and Impact for Minnesota Public Radio and American Public Media. In Focus is a series of convenings NPR is committed to leading over the next year to bring awareness, dialogue, and community solutions to Minnesota's persistent racial disparities. We hope these conversations with community members, shaped and informed by our curious and engaged audience, will encourage new narratives, new relationships, and help Minnesota communities make progress towards an equitable and inclusive future. Additionally, we value your opinions. We want to know what you think of this conversation. If you registered for this virtual conversation through Zoom, you'll get a survey from NPR. Please let us know what you think. We also want to hear from you during the event. If you have a question or personal experience you'd like to share, use the Q&A button to submit it to us. We'll also be watching for questions and comments that come through Facebook. We'll try to get to as many questions as we can. Next, I'd like to acknowledge our In Focus series sponsor, Thomson Reuters, for their generous support. Before I introduce Angela Davis, I would like to acknowledge that we are on Indigenous land. Minnesota is the homeland of the Dakota people who have lived here for thousands of years. Indigenous people from other Indigenous nations also reside in Minnesota and have made innumerable contributions to the region. Indigenous people are still here. They are thriving and contributing to our collective futures. Now it's with great enthusiasm that I introduce Angela Davis, who will host today's conversation. Angela is an award winning Twin Cities news anchor and reporter. She hosts NPR's 11 a.m. program, focusing on issues impacting Minnesota and the region. Angela, over to you.
Thank you, Guy. And hello, everybody. I'm Angela Davis here at NPR News. I'm so excited that you were able to make time for this important conversation today. I'm eager to talk with our guests, and I'm also eager to hear from you. We want to bring you into the conversation, so please feel free to submit your questions so we can share them as we have this conversation with advocates as well as healthcare providers who are all working to address racial disparities in healthcare. We have lived through an incredibly difficult year in which the COVID-19 pandemic, as well as the killing of George Floyd by police in Minneapolis, have really exposed the racial inequities that many of us already knew existed, but many more of us were really forced to acknowledge and address. Minnesota consistently leads, or rather lands on lists that state we have the best healthcare, right? But if you're Black, Indigenous, or a person of color, you're not included in the high marks that the state receives in metrics like healthcare access or public health outcomes. Racial disparities persist in everything from breast cancer to infant mortality to heart disease rates to incidences of injury and violence. And this past year, COVID-19 and George Floyd's killing really sowed additional doubt within BIPOC communities. Are existing systems and the people who operate in them, are they truly equipped and committed to closing the gaps in care and health outcomes? That's what we're talking about right now. What is happening and what needs to happen to really bring about change? I have four guests joining us today. I'd like to introduce them now. If you turn your cameras on so we could see you, that'd be great. Four guests who will be able to really provide us some insight as to what is happening within healthcare because of the unique positions that they hold. With us, we have Antony Stately. Antony is the CEO of Native American Community Center in Minneapolis. Hello there, Antony. Hi. We also have with us Cindy Kaigama, and Cindy is the Director of Innovation and Learning at Minnesota Community Care in St. Paul. Hello there, Cindy. And we also have Stella Whitney-West. She's the CEO of North Point Health and Wellness Center in Minneapolis. Hi there, Stella.
Hello.
Hi. And also, you can see there we have Naomi Windham. Naomi is a nurse practitioner at Hennepin County Healthcare for the Homeless. So all four of you are working very closely with people who face challenges every day, often because of their race or because of their lack of resources. And I know all of you have seen some things and heard some stories. So to get us started, I would like for each of you to tell me something that you're hopeful about when it comes to racial disparities in healthcare, but also tell me something that worries you, that deeply concerns you, that maybe keeps you up at night. Stella, would you go first? Exactly what are we talking about here?
Thank you, Angela. So we'll start off with what am I hopeful about, and a couple of things. One is that I am hopeful about is the fact that we have linked health care and health disparities with this what we call the social determinants of health, because it doesn't happen in isolation. It happens in conjunction with what we're seeing in education, what we're seeing in housing, what we're seeing in wealth gap, and what we're seeing in other livable conditions. So to be able to look at it as one connected network instead of just viewing it in isolation. Um, and I think what the other thing that I'm hopeful about is that seeing more and more of the younger generation coming in to healthcare. I'm very hopeful about that. And certainly, what concerns me, I think, and as you started off, that this last year, 2020, really um, displayed uh, our racism at the height in this community, in this country. And I think all of us were aware of it, but it really took center stage. And I think that that is really is frightening to all of us.
How about you, Antony? How do you describe the racial disparities that we know exist in healthcare, and what gives you hope and what really worries you?
Well, I think my thoughts are that these health disparities have been around and pretty durable for a very long time. We're talking decades, right? There's been significant, over the last 10, 20, 30 years, there's been such small movement, especially in the state of Minnesota, around some of the health disparities as you mentioned earlier when you were doing your introduction. So what I feel hopeful about is that, well, the events that sort of took place over the course of this last year, the pandemic, the COVID pandemic, that sort of kind of laid bare just how, and made it so significantly obvious how large those gaps and how big those disparities were. Right, it really amplified and made it very, 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 very public and very visual. And then the convergence of the murder of George Floyd, and quite frankly, all many of the other senseless killings of Black and Brown people throughout the nation over the last couple of years. Those things became amplified. The nation as a whole sort of kind of got tired of this and sort of rose up um, um, and started voicing their discontent and the quote unquote their unrest with the situation. I think one of the things that and that's a pandemic of sort of institutional racism that has been in place for generations, 3, 4, 5 generations, right? What I feel hopeful about is that that people are finally becoming vocal about it. They're not resting. We're unrest and we're
Mhm.
uneasy and we're making it known and we're holding some people accountable and we're holding the systems accountable. Right? We're not talking about individual people. We're talking about systems. Of course, systems are made up of people, but that's what makes me hopeful is that we are finally seeing this wave um, of a response nationally that sort of kind of took spark here in Minneapolis, in Minnesota. That's hopeful to me. I think the concern that I have is, we sometimes as a society, we get inured in this conversation around race and racial disparities and health disparities, being sort of this sort of like this black and white either or zero sum game conversation where, well, if somebody in another community or some other group of people get some type of asset, it means my group or another group gets less assets, right? So we have to sort of begin to change the conversation around whether or not health disparities or whether or not health equity is a zero sum game.
And Naomi, what about you in terms of what gives you hope and what worries you? You work as a nurse practitioner.
Yes, yeah. I think what gives me hope really are just the conversations that have been exemplified within healthcare systems in the last year. I think that conversations around COVID and disparities related to COVID, but more broadly, conversations around historical trauma, around what has led us to this position and what disparities were there anyway, and what has been done about them throughout the last few decades. I think the exemplification of Black and Brown voices within those organizations has given me a tremendous amount of hope, along with, as Stella had mentioned, just the influx of Black and Brown providers, nurses, medical staff speaking up and speaking boldly about things that not only affect their practice, but affect our entire systems. So that gives me a tremendous amount of hope for the future. I think what worries me just are these disparities, period. We continue to see the same disparities in homelessness specifically. We continue to see that homelessness is a tremendous driver of poor health. We continue to see people having difficulty obtaining just basic medications that they need to survive, which is exacerbated especially in Black and Brown communities. And so just the fact that we continue to struggle with the basics still feels tremendously worrying to me.
And Cindy, lastly there, you're at Minnesota Community Care. What gives you hope and what worries you a lot when we look at racial disparities in healthcare?
One of the things that I'm hopeful about is that in this space in 2021, that we have a insurmountable amount of people who reflect the communities that we serve in this space in healthcare, and that we are becoming in positions of leadership that we can set the tone and a narrative that is inclusive to all people and not just one cultural lens that we've lived from for a very long time, and that the work that we're doing is now impacted in ways whereas before it was one narrative, but now that narrative is widening and the gap is getting larger with the voices and the people that's represented in changing the healthcare system. The thing that I am concerned about, and I have conversations about this all the time, is that this is still a business, and that unless we change the power structure and who controls the dollar and who controls the money, then I'm concerned that because we are now in these spaces and places where we are making systematic change from the lens of inclusion and healthcare, that the people who traditionally control that power will say, wait a minute, we're going to continue to keep this strapped and continue to make billions of dollars off of this business so that we don't give you too much voice, because we don't want to let this power go. So for me, it's from the concern is that we need to change and add more voices to who really controls the power from a corporate lens and from a financial lens, so that we can have a greater voice on that side as well.
I apologize for my monitor keeps slipping here, so I'm trying to adjust it for us as we continue to talk. Anthony, I want to get a better understanding of the work that you do, each of you. But Anthony, you're at the Native American Community Center in South Minneapolis, and so tell me more about the services that are offered there. And you're a clinical psychologist.
So my title at Native American Community Clinic, by the way, not center, is the Chief Executive Officer, but I'm a licensed clinical psychologist, and I've worked in that role throughout over the last 35 years since getting my PhD and my training in tribal communities all over the United States, and also in urban Native American communities since that time. I'm really privileged to be in the role that I'm in as CEO of NAC, because the Native American Community Clinic is situated right on the cultural corridor in South Minneapolis along Franklin Avenue, which is kind of a destination spot for pretty much anybody if they want to sort of kind of know what's going on in the pulse of the Native community and the urban area, the urban core in Minneapolis. But I was raised in, born and raised in this community, and so now I'm coming back later in my life and serving that community, and really privileged and honored to do that. But one of the things that's challenging for me in that role is that over the 4 years that I've been in that role, as I've seen with my own eyes, because I left Minnesota when I was in my early 20s, went away for about 2 decades and started a career, and then came back in my 40s when my children were born. And I see in some ways that the state, my home state, my homeland, my place of my birth, and my early childhood has done some really amazing things in terms of growth and development, and then in some ways, very real ways in my community, we have some worse health outcomes, some worse social outcomes, some worse economic outcomes, and those kinds of things that really impact my community broadly. I think one of the things that we don't often think about when we talk about health equity or health disparities is that we don't recognize how interconnected these things are, that health and well-being is connected to, like, graduation rates. It's connected to whether I know whether I have a home or not, or whether I own that home, whether I have the resources to be able to make sure that my family and my children and my community are safe. All of those things are deeply connected to people's health outcomes. And if we don't have, if we're doing poorly in those situations, in those conditions, then our health is going to pay a significant cost. We're going to have higher rates of mortality, higher rates of all kinds of things. And we see those rates reflected in some of the data that the state collects. We have, Minnesota is 49th in some of the worst outcomes among practically anything you can measure. In lots of those situations and conditions, the only state that's worse is Wisconsin, our neighbor. And I think one of the things that's troubling for me is that, people like my mother, my uncles, my relatives, my grandparents, they worked hard in the 50s and 60s and early 70s to create legislation, to create opportunities, and to turn some of those things around. Minnesota, Minneapolis specifically, was the birthplace of the first urban Indian health clinic, the Indian Health Board. Minnesota should be proud that we were put on the map in terms of developing a response to urban Indian health. And so 40, 50 years later, we should be in a different place with those health outcomes, right? And we're not, and that's troubling to me.
Absolutely. I want to ask a question, as we look at the spread of COVID-19 and the availability and the distribution of the vaccine, finally, I want you, Antony, beginning with you, describe what you're seeing in terms about the attitudes of the vaccine, because we know that there is some resistance to getting it. There's a lot of distrust, even among healthcare professionals. So, Antony, beginning with you, tell me, what are you hearing about? Like, I don't know about that vaccine.
Sure. I mean, I think a lot of it coalesces around and is born out of the historical mistrust that is embedded within the community, just around healthcare, government, government agencies, and whether or not those systems can be trusted to sort of, to think of our needs and to think of our community's needs, and really trust that those things are at the forefront of, from everything from the beginning of, let's think of what the solution here is, to the development of the solution and then delivery of the solution, right? One of the things I hear people saying really early on, as soon as NAC got the vaccine and we started to do our distribution, develop and plan our distribution, I was hearing already from staff, I was hearing from some of my staff, I was hearing from some of my relatives in the community, some of my patients and other folks, concerns. Well, why are they giving it to Black and brown people first? They want to give it to us to find out if it's going to be detrimental or harmful, and they're experimenting on us again, which is a recognition of the history that public health service and the medical establishment and research, the research industry has done to Black and brown people. They've done some horrible things to us in the past.
I want to ask Cindy about this question too about distrust. What are you hearing about people being skeptical about the vaccine?
So I've actually done a lot of research in having community conversations and engaging our clinicians, and we have mixed information. So you have people who are saying, absolutely not. I will not be a guinea pig. I will not continue to participate. From a financial standpoint, that corporations are making money off us, from they're trying to kill us, to I'm hesitant, but COVID was worse, so I'm ready to take the risk, to I'm on board. So we have had all three types of experiences. Proud to say that in our clinic, the majority of our employees and staff have been vaccinated. So almost 70% of our employees have vaccinated, and we have a diverse staff that represent our patient population as well. So that's been a good thing.
And what about you, Stella? What are you hearing about distrust of the vaccine and a reluctance to get it, both among patients and community members and healthcare professionals?
We're seeing the same things that both Cindy and Antony talked about. We did a survey of our staff prior to getting the vaccine, and I have to say that I was a little bit surprised to hear from some of our staff, healthcare workers, that there were about 20% that just said that they definitely were not going to get the vaccine, and a variety of different reasons, some that have already been said. Concern about how the vaccine was developed. It kind of came on the scene too fast, mistrusting, not really sure if all of the side effects, and not really even understanding around the clinical trials, because oftentimes people of color have not been involved in the clinical trials. And so a vaccine or medications will be developed, but not developed with our communities being part of the trial. So not really understanding how it will impact us. I'm happy to say that many of the people on our staff who said definitely would not take it have now taken it. And so we have close to a 90% rate of our staff who have taken the vaccine. And a lot of it had to do with providing the education, having them to see also their coworkers, other providers who stepped up, took the vaccine, and then to be able to see, because there's a lot of information that's out there that does show and demonstrate that many people of color were involved in the development of this vaccine, and that it wasn't just a overnight, that they've been working on this methodology for decades. So that really helped. And I think too that we're starting to see that as well in the community. And just as Antony has said, that the distrust comes by within the communities of color because of the history, the historical trauma, racism, where many of our folks were experimented on. And even still to this day, many of patients that come to us from other health systems have said that they were not believed when they were trying to explain what they were feeling. They were not believed. And so there's this ongoing distrust. But I also believe that when you look at the devastation that COVID-19 is having in the community at a very fast pace, it really pushes people to having to look at the alternative. You see people that are dying every day because of this virus. And so here's an opportunity with a vaccine to create some safety for yourself and for your family and for your community. So I think that that is why people are stepping up to take the vaccine. And I will also say, putting in a plug for the community clinics that are represented here, a lot of it has to do with the fact that we are considered trusted providers. And so having the vaccine available to the community clinics, the community healthcare providers, where we already have a relationship, there is a trust factor there. And so our patients, our community are coming to us to get the vaccine.
And Naomi, I want to get you the way in this before we get in some of the questions from our audience. As a nurse, what are you seeing and hearing among your peers as well as patients about the vaccine and whether there should be trust in it?
We have a substantial amount of hesitancy just within our patient population. Again, to speak to what other people have already said, historical trauma is strong, and our patients have memories of difficult encounters with the medical field, and so because of that, we just struggle to get a lot of buy-in from our patients. And so one approach that we have taken is to have just authentic science-based conversations with our patients. We are within the shelter system, so our clinics are actually located in many of our shelters, and our outreach team goes out to camps to meet unsheltered individuals. And so we have over time built relationships with the patients who are residing there. And so we have just encouraged our staff to have authentic conversations during clinic visits as they're interacting with patients, just to ask, how are you feeling about vaccinations? What questions do you have about the COVID vaccine? What have you heard from your community? If it was available to you today, would you take it? Why and why not? Just to normalize the vaccination process, but also to dispel some myths as well. We've also seen some hesitancy within our shelter provider staff, so the staff that work day in and day out at the shelters, and we do feel a responsibility to them as well to provide education. And so we've set up a program to outreach to them as well. Many of them will be offered vaccines at the same time as our patients, and so they then become really good advocates for our patients when they're going into vaccination. So I think for our staff, it is part of it is a recognition of history and understanding for our staff of history as they go into these conversations, and then just giving them the knowledge that they need to adequately and accurately describe the science, to speak to the number of Black and Brown people that were involved in these studies, to speak to the outcome of these studies, to combat some of that. Some of the misinformation and some of the myths, as well as some of the very, very real and understandable fears and trauma.
All right, as we talk about racial disparities in healthcare, I want to bring in some questions from our listeners and our viewers right now. And a couple of people have questions about telehealth visits. Dan in Minneapolis asks if they can be a solution, especially during the pandemic. And Rika is asking if telehealth will exacerbate racial disparities. Anthony, I'll give you a go at that. Again, you're a psychologist. Is telehealth going to be the cure?
Well, I think I think it's a really great solution. I think that sometimes one of the things that I think we struggle with as a society is we try to always look for the silver bullet, right? We always try to find that one thing that's going to sort of make everything better. And the reality of it is that these issues that we're discussing are multifactorial. There's a lot of different things that are going to have to come to the table to be part of a comprehensive solution. But one of the things that NAC, and I know that Stella's operation and Minnesota Community Care as well, a lot of my sister community health centers, we pivoted quickly in early February or early March, right around the time that the shutdown kind of happened, or when COVID was like right here on our doorstep. We pivoted quickly and we launched we moved all of our operations to telehealth. We were able to do it fairly rapidly. NAC is a much smaller outfit than in comparison to Minnesota Community Cares and to North Point. We have smaller staff, smaller number of patients we serve. But we were well positioned to do that because we had started developing the capacity to telehealth with some of our tribal partners in the north the year prior, where we had started testing out the technology and a few other things. That was just sort of like happenstance and serendipitous that we had done that. It allowed us to pivot very rapidly and sort of move everybody to telehealth very rapidly. Within a week, almost all of our behavioral health and almost all of our medical operations were being delivered by telehealth. And people had some challenges. One of the things we found very early on was that a lot of people didn't have stable internet. They didn't have the ability to sort of connect. They didn't even understand the technology. And so we had to throw a lot of resources behind doing things like, giving people tablets, giving people the, data cards so that they could connect with their provider, and they could come in and still continue by telehealth and still get their visits. We had to do things like use our medical assistants who would normally like room you in a physical room when you came into the clinic. Well, we had to have them help people connect to the technology, walk them through how to do it, get them into a virtual room and help do all that handing off. And my staff were amazing. I think I have the best staff on the planet. I know Stella would probably argue with me about that, but I think I have the best staff on the planet.
Stella, I want to ask you about this. You're there at North Point, and North Point has a long history of working well with BIPOC communities and establishing trust. And do you think that that plays a big part of this, having so many staff members who look like their patients? What have you seen? What does that do?
Most definitely. Our dental director, who's African American, he often tells the story about a young African American boy who came in to the dental clinic and had a little bit of anxiety, but did not at first recognize that his dentist was Black. And then when he realized and he looked and he kept looking, he says, well, you look just like me. And it just kind of just took away that anxiety and allowed for this child to feel comfortable. And so that is one of the main factors. And then also because your provider or the staff that you're working with is from the same community, they have the same experiences that you have had. So you don't have to go through the struggle of trying to interpret some of the concerns that you have, because now you're talking with someone who has had the same journey that you have, and not only that, but understands the culture that you come from, and culture is a big piece of the healing process in medicine, and oftentimes we don't acknowledge that. Certainly in mainstream medicine, they have not acknowledged that, and I think that when you have providers in clinics where you have people of color who can openly and authentically practice their culture along with the medicine, you have better outcomes. And so that is a big factor, and it certainly has been a big factor in North Point or Pilot City's history over the last 52 years.
Why are there better outcomes? Because patients take the advice from their doctors or nurses and better, or they do better in responding to the advice or the guidance that they're given?
Well, it's also that that and the fact that that they will come in more often for those primary care preventative visits, because and the fact is that we also in community-based clinics is that we provide a variety of services. So, for example, at North Point, we have a large food shelf. We provide assistance with housing. We provide assistance with employment. So understanding the complete experience that impacts an individual's health and well-being, and being able to provide that, as we say, under one roof and through one door. It is real difficult that if somebody has diabetes or other kind of chronic disease, and if the only thing that you're focused on is about the insulin, or about, and you're not asking questions about their housing, as Naomi was saying, is that if someone is homeless and you're living in a homeless encampment, I'm sorry, being able to manage your diabetes is now become significantly more difficult, and in many cases you're not able to manage it. So if you're not asking those kinds of questions, you're not able to get at the kind of the root cause of why somebody's disease is out of control.
Cindy, you're there at Minnesota Community Care in St. Paul, working as the Director of Innovation and Learning. What do we know about the impact of hiring people who look like the patients they serve? What has your research discovered there?
There is data that also indicates that when you do hire people who represent the populations that you have better experiences with the patient and outcomes. Also, it makes trust even better amongst your patient, where they can open up more. Whereas if there were a person from a different ethnic group that they didn't maybe feel comfortable with that, or even understanding a need. I know of an example when a person was telling a provider that she gave her children pot liquor when the child was sick, and the woman was
gave her what?
Pot liquor. So pot liquor
what's pot liquor?
Yeah, I was about to explain it. So pot liquor is when in the South, Stella may be familiar with this, is the greens, Angela. So when you're sick, you give the child the vegetables and the broth to help them with nutrients versus medication, because that's when our culture historically and our ancestors gave their children the greens, the pot liquor from the green, to help them when they're not feeling well. So this is an example of when I was working with Minnesota Community Care as a researcher, that came up where an African-American woman went to a clinic that Euro-dominant providers, that was a care team. And they asked her, what did she provide to the child when the child was sick? And she said pot liquor. So instead of them asking, well, what is pot liquor, like you just did, they, contacted social services.
They made assumptions.
Yes. So when you have providers who that's not even an ethnicity thing. That's just asking a question, right?
That's a curiosity thing.
Right. So you operate from the lens of curiosity, operate from the lens of humility. And, I totally honor and respect that we bring our full work to the table when we operate from the lens of cultural sensitivity. But then there's certain things like just asking simple questions from a human lens, to not make assumptions that we're so sensitive because a person doesn't represent our community that we can't be open. So trust also comes in a way that you have a provider that trusts you, that listens to your lived experience, that respects you as a human being, and not make assumptions that because they're the provider with provider privilege that you don't matter and your voice doesn't matter.
Yeah, that's a respect thing. I mean, if someone says like, I don't understand what that means, could you, explain what that is? Wow. Naomi, I want to ask you, tell us what it's been like for you working with patients of color who need care. I assume a lot of people, when they see you walk in the room, they're like, ooh.
Yeah. I mean, and putting it blankly, the majority of my patients are not used to having Black providers who look like them for the most part, because most of our patients are Black or Indigenous. I think for most of them, it is a sigh of relief in some ways, because they're just not used to seeing people that look like them, that have what the other panelists have already said, just that basic level of cultural similarity, or that basic idea of trust from a racial perspective. And I think that it definitely helps with basic buy-in from patients. I think it also just gives me some context into their struggle in some ways as well. And I think it does help with trusting. I think that when I speak, that my patients in general feel more free to answer questions, and in just my basic opinion, I think that they hear what I'm saying maybe in a different way.
I want to throw
Angela,
this
can I
question.
just jump in really quick and clarify
Yes,
something?
Cindy. Yes.
So I just want to clarify that it wasn't one of our providers from Minnesota Community Care who called the social services. It was an example of a story when I was a community researcher and we were getting feedback from our community and how to improve and make changes in organizations. And that was a story that came out of their community research.
All
I
right,
wanted to just clarify that.
That's my story too now. I'm looking forward to learning more about the pot liquor. I feel like I missed out as a child. I grew up in Southern Virginia. I didn't know about that. I want to bring in a question from Rachel in Edina. She's saying, I am a white healthcare provider. How can I be part of the solution to healthcare disparities? There have been lots of conversations about what our white allies can do to help with these racial disparities and many aspects of life. But in healthcare, we have a woman here who says, I'm white. And so sometimes I feel like we're preaching to the choir when we're talking about, issues that people of color face. What can people, white doctors and nurses who are aware of this and want to see a change, what role do they play in this and what can they do? Antony, do you want to go first on that?
I think the person who asked the question has made a good first step. They're at least recognizing that there's something that they don't know, right? And they're recognizing that they have a need to understand something. So that's a big part of the challenge. I think one of the things, we've been talking a lot over the last couple of minutes here about culture and how important that is, and cultural humility, understanding just operating from a human lens and a perspective of humility, and recognizing, like, just because I'm a doctor, I'm not necessarily going to know everything that I need to know, that my patients are a good source of information if I just take the time to ask them an important question about their life or their lived experience, those kinds of things. But I think it's also recognizing that Western medicine isn't the solution to all things, right? Over the last couple of years, NAC has worked really hard at creating and delivering cultural healing services at our clinic. We hired 2 elders and residents, 2 women who have been trained in some Western practices, but they also have been raised and have learned and have good knowledge of Dakota and Ojibwe healing techniques. And we've been able to integrate those things into our clinic. And it wasn't a really simple thing to do. It was actually a really, it was challenging over the last year or two to get some of my non-native and non-Indigenous or my white practitioners to sort of be accepting and understanding of that and the role that had in sort of helping our patients to, improve in their health and well-being. And I think one of the things that's really important, there isn't a tremendous body of research on cultural healing and its efficacy, such like there is in Western practices. We're starting to see some of that research. But I think the other part of that is also recognizing that that health and well-being isn't just the absence of disease. Health and well-being is actually the presence of the things that make us feel good, that make us feel a sense of purpose, that bring joy to our lives and help us understand and optimize our ability to live in a good way, right? And that's what, at least in Ojibwe and Dakota culture, that's a lot of what our healing ceremonies and our traditional practices are about. Like, how can we be a good relative while we're here? How can we maximize our experience for ourselves and our loved ones and our community and our families? And how do we show up and do the best we can in that space?
I'm curious, what are the conversations are you having with your fellow nurse practitioners who are white, or doctors who you work with who are white? I mean, what do you talk about? Do they ask you questions?
Yeah, some of them do. I think my basic advice always is to ask questions. So for my white colleagues, for my white friends who are providers, to ask questions to get a deeper knowledge of the history, to get a deeper knowledge of what makes what is foundational to cultural diversity, what is foundational to healthcare diversity, where is the disparity. And I think that if they can come at it from an area of humility, from a mindset that says, I don't know everything, and that my whiteness does play a factor in the care that I provide and in the way that I look at my patients in just a basic sense.
Exactly.
I think that is the posture to come at this work. That is the posture to walk into every single patient visit, to understand who they are, what the context is, what their whiteness says about the visit, and what their whiteness says to the patient, and how they can continue to be a effective provider and a good advocate to their patients within that context.
Cindy, what
That's
should
true.
we be talking about with our white allies who want to jump into this particular battle when we look at healthcare?
So there's a level of fragility that comes in this space that people who have traditionally been leaders in the space, and now you're asking them to be vulnerable, and that becomes extremely uncomfortable because you may hear about things that you traditionally are the leader in. So now you have to hear from a voice that does not necessarily have your lived experience. So I think that it's really important that in our space, and I know in my space, I was told to be uncomfortable being uncomfortable, be comfortable being uncomfortable, because those conversations may come up, may trigger something in you that it may trigger you to be extremely fragile. So you have to be fragile from a sense of I'm doing this and I'm being fragile and vulnerable so that I can make change and systematically improve outcomes for this clinic, and also from the lens of healthcare and not just from the lens of a savior. So you have to do it from the lens of I am providing culturally cultural humility and culturally competent care from the lens of a ally, not from the lens of a savior and from fragility.
And Stella, finally, any advice for white allies who work in healthcare and have an opportunity to be very impactful? What would you say to them?
I certainly agree with all that my colleagues have said, but I also will add this. I think it's extremely important that they understand the history of racial trauma in this country, and understand that people of color, because there's always this philosophy that individuals have made a choice, in that, oh, if you just work harder or if you just do this, then you will be successful. And that if you are not, then it's because of something that you have done.
Mhm.
So I think that they really need to understand that from that historical perspective, that for people of color, BIPOC communities, that there was something that was done to us, and to truly and understand as well that they were not taught that our white allies did not learn the history,
All right.
the true history of what happens to people of color in this country. And so they need to understand, and they should be upset as well that they were not told the truth. But now that you are woke, seek out the truth and know that what you were taught in school was not the truth. And then, as what my colleagues have said, approach your patients, or approach people of color from a position of asking questions, and then believing them,
Right.
understanding, and don't always approach it from, again, from a level of, well, just because it's not part of your culture or part of your journey, it must not be true, it must not be valid. But
And
believing and then asking those questions.
we have a question here from a nursing student who is studying public health. And this student asks, how can we recognize the generational trauma from healthcare abuse, obstetrics, and gynecology,
Mhm.
forced testing on enslaved women? The Tuskegee syphilis study was an unethical study on Black men. How can we address this? And Naomi, I know that you have, dealt with a lot of the past experiences that many women have shared with childbirth And you hear a lot of stories of bad experiences that I know, in particular, Black women have described in giving birth. What can you share with this student and about that?
I think that sometimes people don't even realize that where the trauma comes from. So part of it for me in my work with pregnant women and in my work with women postpartum is to provide context to that education for them. I think that as a nursing student for this particular person, for them to, it sounds like they have some understanding of some very significant pieces of historical trauma for Black Americans, but for them to make sure that they are sharing the knowledge that they have with their colleagues, with their classmates, with other nurses who are coming into the field. And that, again, to be aware when they're interacting with their patients, aware of that historical trauma. I think that one thing that I think others on the panelists have spoken to as well is that white supremacy and white dominance in healthcare makes it very easy to go into patient situations and kind of forget that stuff. But it is, I think, essential to providing good patient-based care to Black women in the United States is to come into the visit with that knowledge and not forget, to choose not to forget as they are interacting with that patient and those patients. And that has to be a conscious choice.
Adrian in the chat is asking this: can the panelists talk about Latinx issues on healthcare? Latinx people are testing positive at 3 times the rate of white people. Their voices are often missing in these conversations. Why is this, and how can we all work together to amplify all of our voices? Cindy, can you speak on that?
Yes, actually, this is something that just came up at our organization because of La Clinica in Westside St. Paul and the number of patients who have tested positive for COVID. And we have just identified some data to see what can we do to engage our patients and hear from them to see how we can assist and provide resources for people who have died or who have had COVID, and what are the long-term consequences now that having experienced COVID, and talking to them in a way to be curious to find out how we can help. Another thing that we're doing is we have a vaccination and a COVID team that we created. And our director of equity and inclusion identifies as a Mexican American man who is leading in partnership with that charter to address that need in our Latinx community. We will be creating messaging in different languages that also provides facts and information to dispel myths about the vaccination, and having our people who we work with in our organization see how we can help the communities that are being served and the impact that has had on their lived experience with COVID, and also deaths that have occurred because of COVID.
And when we look at data, we know that Black Americans are infected with COVID-19 at nearly 3 times the rate of white Americans. This is research from Johns Hopkins University, and which also shows that Black Americans are twice as likely to die from the virus. And so, Stella, in your interactions with, Black patients, is this something that your staff is sharing with them?
Yes, for sure. And I think what's important is that our patients bring that experience to us. So we don't have to give them the statistics. They will start telling us about family members that they have lost to COVID. So again, they are living the experience, and so that they know that. I also want to say that, and Antony may step in here, that when we look at the high rate of death from COVID for our Native Americans, it is extremely high rates, and oftentimes that goes unnoticed. And then I wanted to address the question about the Latinx or Latino population. You just saw my daughter back there, right?
Go right
So,
ahead.
so 30% of North Point's patients are Latino, Latinx population. And so one of the things, and we certainly saw this with this last administration, the the demonization of the Latinx, our Latino brothers and sisters, and the whole idea of they having to operate almost in the shadows, right? Because of that, of the fear of being deported, the fear
Right.
of being, even to the fear of that many of our patients felt about even seeking health care. Where they're going to be identified, or where's ICE going to show up and they would be rounded up. The fear, can you imagine, of seeing parents being separated from their children, enormous amount of stress and trauma that they experience. And so we have to recognize that and understand that that is their journey, and the fact that they are not even recognized for the fact that they are many of the frontline workers who
Right.
are working and not getting credit for it, are the undocumented workers, but that are working in those jobs that fuel the economy of this country. So I think we have to make sure that we recognize that.
And before our time is up, one last question from one of our listeners. Madeline in St. Paul is asking, what do the panelists think is the most doable in reducing systemic racism in healthcare in Minnesota? And so if there's something that we could do right now that would be highly effective, what would be at the top of your list, Antony?
The most doable thing would be is to encourage folks who are allies, who recognize some of this work needs to be done in small and large systems, to start using their voice to bring that to attention. I think both Cindy and Naomi sort of recognized that the majority of healthcare and healthcare leadership is not people of color. It's white physicians, white doctors, white executives who are in the positions to make decisions about how certain things get done within their healthcare systems. So having an ally within that system that sort of begin when they get to the point where they recognize that there's some significant work to be done within their structures and within their systems to use their voice and use their power, use their privilege, right? Whether it's earned or unearned, to say something and to shine a light on this problem and these challenges, and that's got to be one of the first steps we do. We have to begin to start to say, like, this is unfair, this is inequitable, this is
To speak up, see
yes.
something, say something, right? Naomi, briefly, what's most doable to address these disparities?
I think investing in people of color in terms of healthcare leadership, looking not only to people of color within the organizations for answers, but investing in them to step into roles of leadership to help create systemic change.
Cindy, what can we do right now that would be effective?
I think we need to release the bag. Like, we need to put some money into this that are larger rates, and to give us some of the coins so that we can do our work effectively, and so that we can make change and don't be so stingy with the purse. I mean, if you look at it from that lens, from a money lens, like, we need to release funds into our communities that we have control over, so that work for us, and not given parameters and restrictions on how we use these dollars, but that we're leading the charge to impact the communities at their most risk.
Stella, what would you say? What's most doable? What could we do right now that would make a difference?
Well, one of the things that I say this to everyone, our white allies and also people of color, understanding clearly that healthcare is also politically determined.
Exactly.
That, and if we haven't learned anything by now, we shouldn't understand that who is your elected officials, who are the policymakers, who has the power base, right? They make the determination who has access to healthcare. And I think it was Cindy that said that healthcare in this country is a big business. Let's understand that as well. And I think that for communities of color to understand that you can organize, you can vote, you can actually change outcomes around healthcare, also politically as well. And so we need to make sure that that we are doing that on a large scale.
Yeah,
And
Angela,
then,
weigh in
yep.
here on the tail end of Stella's comment, because yes, political power is really critical here. For Native Americans, we are different from the rest of the population of BIPOC people in that we have a government to government relationship with the federal government. When Native Americans gave up land and gave up other resources that were rightfully theirs because of their right to sovereignty, they gave those things up in every single treaty that was ever signed by the United States. There was a guarantee of certain things that the government was going to, in return for those riches and the wealth that was embedded within that land, that they would do certain things. And healthcare is one of those things. And so a lot of the work that I do is to remind governments, state governments, federal governments, people who are in positions of power to make those decisions, that in the conversation with me and Native people, this conversation looks differently than it does necessarily for just BIPOC people or other people of color. That there is you have a requirement, a government to government and legislative requirement to pay attention to this.
All right, well, our time is up, and I want to thank all of our guests for their knowledge that you all have shared with us today, and to thank our listeners and our viewers for your questions and for joining us. Everyone who gave us some of your time today, we appreciate you. Again, our guest today, Antony Stately, CEO of Native American Community Center in Minneapolis, Cindy Kaigama, Director of Innovation and Learning there at Minnesota Community Care in St. Paul, Stella Whitney-West, the CEO of North Point Health and Wellness Center in Minneapolis, and Naomi Windham, a nurse practitioner at Hennepin County Healthcare for the Homeless. Thank you so much. And for all of you joining us, our next In Focus event, because we do this every month, is Wednesday, February 24th at noon. I'll be with you, and we'll be talking about re-entry after serving time behind bars and what we can do as a state to better support people who are making that transition. Again, mark your calendars. That is Wednesday, February 24th at noon. Be safe, everyone, and thank you for being with us here at NPR.
Thank you. Thank you, Angela.